Well, hello and good morning, everyone. Thank you for joining us today for our CAS webinar on Dialectical Behavior Therapy as a school-based social emotional learning program. I'm Bill Silva. I'm the Associate Executive Director at the Connecticut Association of Schools. I'm here with our distinguished presenter, Dr. Alec Miller. Before I introduce Dr. Miller, I want to thank our corporate partners, IGA and Jostens, for their continuing support of CAS professional development for principals and all educators in Connecticut. I also want to go over how we will proceed today. During Dr. Miller's presentation, you in the audience are muted. I do encourage you to share any questions you have using the Q&A feature on your screen, which I will be monitoring. Dr. Miller and his colleague, Dr. Alicia Dadd, will be answering questions after his presentation is concluded. We are also recording the webinar, and we will make it available as soon as we can in the next few days. And now let me introduce our presenter. Dr. Alec Miller is a clinical psychologist, teacher, researcher, and author. He is co-founder and clinical director of Cognitive and Behavioral Consultants, a private group practice and training center based in White Plains and Manhattan. He is also a clinical professor of psychiatry and behavioral sciences at Montefiore Medical Center, Albert Einstein College of Medicine in the Bronx. Dr. Miller is an expert in the treatment of stress management, adolescent depression, suicide and self-injury, borderline personality disorder, as well as dialectical behavior therapy. Welcome, Dr. Miller. We're privileged to have someone with your expertise and experience to speak to our audience today. Thank you for being here to present on this essential topic, especially during this challenging and most uncertain time. I now turn the presentation over to you.
Well, thank you, Bill, very much for the warm introduction and to the organization CAS for inviting me today. I really appreciate it. It is a pleasure to be here, and it is a challenging time indeed. So I have a privilege to speak with you. My outline for today, my ambitious outline, is to try to cover the mental health challenges of our youth in the 21st century. I want to discuss what I believe the need for social emotional learning and building resilience, and it's especially more important now during this pandemic, right? Never more important. And the way that we at CBC, my colleagues, do it is through the lens of dialectical behavior therapy, which was originally a clinical intervention that I had adapted with my colleagues for adolescents years ago. And we've spent the last 12 plus years bringing this into schools from a tier 1 to tier 3 level. They're basically, as we talk about this, life skills for everyone. I use these skills and DBT skills myself and my family, my colleagues, and I certainly find these useful for school staff, for parents, and of course for our students themselves. So we are going to be going over those different applications of DBT in schools, and I want to conclude with some hope for the future. But to start out, we all know how challenging this time is for our young people and adults, school professionals and parents alike, right? These challenges of the pandemic are unprecedented. The challenges of unemployment and food insecurity, unprecedented. The challenges of racism and social justice challenges are unprecedented. So they are all converging into this perfect storm. And frankly, anecdotally, I see a lot of mental health challenges that are happening in relation to this. But I'm afraid we are on the precipice of a mental health pandemic that will be the sequelae of this perfect storm. And we in schools and mental health centers are going to be faced with major challenges. So this is why I am very concerned. Now, even pre-COVID, schools have been the mental health front line, with most mental health services for kids happening in schools, right? You guys have the most contact with children, and we know outpatient centers can be expensive. They have long wait lists, not always accessible. And so the number of outpatient sessions is often low. And I imagine in your schools, going back to last year and certainly going into this fall, I'm sure you're seeing higher incidences of emotional disturbance classifications, ED. Probably school counseling demands are going to be going up, more special ed referrals, and I'm afraid also more school refusal behavior for understandable reasons and some reasons that are psychopathological as well. So there's a lot of challenges that are going on. But the impact on you all, on the school staff, even pre-COVID, right? The burnout in education is well documented. 1 out of 4 teachers has felt burned out at any given time, and they're 3 times more likely to quit than similarly trained professionals. The distress level among teachers is very costly in terms of annual absenteeism, turnover, and so on. And you know, the burnout is for many people who work with young people who are in high stress situations, whether it be school settings and clinical settings that I have also worked in, is high. And so we have to attend to the burnout. We have to assess it. We have to intervene. We have to treat it. And this DBT intervention that I'm going to be presenting to you today actually attends to the staff as well as the students. And in fact, we're doing a study now to look at whether or not our interventions of implementation of DBT in schools is helping with staff burnout as well. And since COVID, we know there's increased shortages. We know up to 45% of principals are reportedly leaving their job earlier than planned. And of course, the demands of always being on. So now let's turn our lens to the children. Pre-COVID, in any given year, I want you to keep this number in mind. At least 1 in 5 children and adolescents has suffered from an anxiety disorder, which of course disorder means impacting of functioning, impairment of functioning, academically, socially, familially, occupationally, and so on. 1 in 5 have reported depression. In terms of high school students, 1 in 5 reports at least some form of non-suicidal self-injury, as well as suicidal ideation. So there are a lot of kids who are suffering in your school buildings and classrooms as we speak, pre-COVID. Now, we know the anxiety has been increasing for years among American teenagers. And why is that? Well, let's be clear, they are more busy and digitally distracted, not only the students, but we as parents, the adults in the room, the teachers, the therapists, we all have to be mindful of that, the rising pressures. And the I generation, the kids born between 1995 and 2012, who grew up with internet access, grew up with smartphones, grew up with social media. I'm going to talk about the impact of this, and I have some data to show you in a moment. But the paradox of this I generation is that there's lower social support. Even with all the social media, there's lower social support. I would argue that the pendulum has swung, again, pre-pandemic, into maybe offering too much scaffolding in our communities, in some communities at least. And of course, the kids are dealing with perceived and legitimately real dangers, school shootings, terrorism, COVID. Am I going to school? Am I not going to school? Can I be on a playground? Can I be at a friend's house? They know people, including their own families, who are dealing with unemployment. And of course, racism, again and again. Now, when I go to school presentations and I have the opportunity to talk to school staff and parents, and I love going to PTA meetings, by the way, and talking to parents, they say, what are some good books, Alec, you recommend? So here are some three that I've kind of been recommending the last several years. One is Jessica Lahey's book called The Gift of Failure. You can infer from the title. What I mean by this, and what she means by this, is there are benefits to having to struggle sometimes, to deal with frustration, to not have everything resolved for one when they are having a challenge, and to certainly scaffold them, give them some help, but they don't have to be swooping in and we rescue them from every challenge and problem. There are benefits to not always being number one all the time. The iGen, I'm going to talk about Jean Twenge's book, The iGen, and Michelle Borba's book called Unselfie. Now, in her book Unselfie, she talks about empathy. And God knows in this moment in our world, in this divisive, polarized world that we're living in, we need to cultivate greater empathy for one another. And it can be taught. And emotionally attuned kids, it turns out, are physically healthier, do better academically. And so I really do think, let's not lose sight when we talk about social emotional learning about empathy. And I'm going to talk about this notion of mindfulness, being aware of our own feelings and reactions, being aware of judgments, trying to increase compassion for others as well as ourselves. So this is it folds into the DBT skills of mindfulness in a moment. But this selfie syndrome, I'm sure some of you have seen some version of this in the last 10, 15 years. This is a condition that many young people engage in self-promotion, personal branding, and self-interest at the exclusion of other people's feelings, needs, and concerns, right? You know, these Snapchat maps, people know, oh, my friends are hanging out all together without me. It is so problematic. People feeling left out, and this fake, you know, everyone's so happy over here, right? These kids are starting to feel like I'm being left out. There's something wrong with me, and there's real evidence of impacts on anxiety and depression on young people who are on social media. And Michelle Borba talks about why we should be concerned about the selfie syndrome. There's measurable dips in empathy, increases in narcissism, more peer cruelty, more cheating, weaker moral reasoning. And she says that our plugged in, high pressure culture is leading to a mental health epidemic among our young people. And this was published 4 years ago. Now, prior to the pandemic, I had been observing as someone who lives in Westchester County, New York, who has 2 kids now in high school, senior and a sophomore. I've coached many teams of soccer, basketball, softball, and other things over the years. And I have noticed in my community and others that the parents often dish out what I believe to be over-exuberant praise at times, and always inging, I call it, over solving, rescuing. And I'm afraid that if we give everybody a trophy for every single thing they do, we inadvertently create this sense of entitlement. The world owes me. And this then carries on, interestingly enough, that Michelle Borba talks about. Professors in college are talking about these entitled kids who want to go on vacation and tell the professor that they need to switch their testing date for the class because they're going to be away and that should be moved, or their B has to be adjusted to an A because they worked hard and therefore they deem themselves deserving of an A. And now some parents and students are saying that the red pencil and pen that the teachers are using in grade school to give feedback to students on their tests or papers is too harsh. Can't handle the red ink and pencil, gotta switch to purple. Can't handle the red. So think about, we are fragilizing, we are fostering this inadvertently, fostering this, you are so special and fragile, and we're not going to do anything to have you feelings hurt at all. I want you to think about what the long-term implications of this is. So an overhelping parenting style, and it's not just parents, it can be other folks too, but where we swoop in and we make it tough for kids to learn the crucial skills like coping and decision-making and problem solving and empathizing. And when I was giving the presentations a few years ago to my colleagues in Norway and talking about there are some subgroups of parents in the United States, helicopter, bulldozer, all these little terms that we use, they said, oh, you know, we have this in Norway, Alec. It's called parental curling. And some of you may be familiar with the Olympic sport where you throw a disc down the ice. You can see the picture on the bottom of the slide. Visualize those as parents in the front. They're sweeping the ice so that it's totally smooth and the disc can come down and land so perfectly. And it has been kind of preempted by the parents swooping in. So I thought that was a funny visual, and yet when you think about it, it's quite upsetting if it is actually happening day to day. Because all that doing may inadvertently send the message to our kids, I'll help you because you can't do it alone. So not only are we fostering entitlement on one side, on the other side of the coin, we're conveying you can't do this yourself. You can't handle the truth. You need help and I will do it for you. Your college essay, I'll take care of that. Your history paper, I'll do that for you. You know, you have a problem with your teacher, I'll make sure your class is changed. Do not worry. I'll take care of that for you. So there is some of this societally happening pre-pandemic. I don't know, I can't say this is going on in the midst of the pandemic, but I am concerned because the data suggests this is part of what's impacting our kids functioning in college with higher rates of anxiety, dependence, depression, and even suicide. So I'm going to show you more data on that in a moment. But let me switch now to Gene Twenge, the I generation, right? So these are kids, like I said, who were teenagers right when in the early 2000s when the smartphones were released. And she studied large swaths of populations of youth over the years. And you can see, it goes back to 1985 to 2015. She looks at 8th, 10th, and 12th graders. And what happened in 2007 is the iPhone was released. After that point, there's a precipitous drop where the kids say, I'm not hanging out with my friends, much less. They stop hanging out with their friends and they're hanging out with their technology. Correlationally speaking, the same period of time, the kids started feeling increasingly lonelier. Again, these are thousands of students who were evaluated, a lot of times feeling lonely every day. You may have noticed some of these kids are also less in a rush to drive. They're happy to be home. They're happy to have you drive them. They're not in a rush to drive. And because they're not going out as much, they're not driving, they're not socializing, there's less dating. There's also less sex happening. And as a result, they're also staying up much of the night on their technology, not getting sleep. Now, when I ran the adolescent depression and suicide program at Montefiore Medical Center for 20 years, I worked in this outpatient clinic, mostly ethnic minority youth, Hispanic, African American, where we originally developed DBT for adolescents. There was a multitude of problems these kids were presenting with. And sleep, falling asleep, staying asleep, that was a problem too. But on the laundry list of problems, we put that at the bottom. Until we realized what effects sleep have on young people. Now, we all knew that if you have real insomnia and sleep problems, it can precipitate a depressive episode or exacerbate a depressive episode or even a bipolar episode. We all knew that sleep could affect anxiety, exacerbate anxiety, affect attention and concentration. But what we didn't know until the study that I published in 2016 with my colleagues is that sleep disturbance, meaning trouble falling asleep, staying asleep, or waking up early, had a correlationally impact on increases in suicidal ideation, non-suicidal self-injury, and suicide attempts. So this was eye-opening. My goodness, we cannot poo-poo sleep problems. We got to figure out a way to help these young people not stay up all night, not be distracted by their screens. One of my proudest moments as a parent, and I have plenty of non-proud moments, was my wife and I told our kids when they got their smartphones years ago, they will stay outside of their bedroom, in the kitchen, and not accessible during the night. But it's a lot to think about how to help families and students separate, unplug from these phones, unplug from laptops, unplug from TVs, and try to be able to relax their brains. A lot of these kids think they're mobile crisis team operators. They have to be available 24/7 in case their friends are in distress. I tell them there are actual professionals who do that. They don't have to do double duty, being a middle school or high school student, as well as a mobile crisis team operator. There's plenty of opportunity for other people to share that load. Here's the thing. This number just kind of came out. It's usually 2 years behind because the CDC has to collect morbidity, mortality reports. 48,000 Americans have died by suicide this past year in 2018. When I got into the field running this clinic at Montefiore in '95, we had 30,000 suicides. And the Surgeon General said we had a real epidemic. So think about that ratio of increase over the last 25 years, which means that by the time my presentation is over, another 8 or 9 Americans will have taken their own lives by 11:30 this morning, okay? And look at the suicide to homicide numbers below. 156% more people will die by suicide. It's 2.5 times the number. You don't hear about this necessarily on the news as much. Now, this is personal. These numbers are personal. When my father was 17 years of age, his father had worked at Gimbel's department store in Manhattan, was laid off, and sadly and painfully went home and hanged himself in the basement, leaving his wife and 3 young children behind. Okay. I had one of my dear former psychology interns died by suicide maybe about 5 years ago, leaving behind 2 young children. And many young people also died by suicide. There was a young man in a neighboring town in Westchester who was a spectacular basketball player, high school senior, ready to go to college, and took his father's service revolver and shot himself dead. There are many people in the schools and communities in Connecticut, New York, and around the country where there are thousands of young people who are dying by suicide. And I just want to put this out there because this is a responsibility for us to identify and treat these kids. And it's not, you may be surprised to know, depending on the year, about 1 out of 5 kids seriously consider suicide. And so that means, and by the way, there are about 8% of whom attempted suicide, 3% of whom made an attempt requiring medical attention. So that means about in every typical high school classroom, 1 boy and 2 girls may have attempted suicide in the past year. Doesn't mean they all got medical attention, but that's what these studies are telling us. So suicide is a real issue. Obviously, it's near and dear to my heart. I'm hoping it's not as impacting as many of you, but it may. And I'm 100% certain that non-suicidal self-injurious behaviors are happening in your schools as well, whether we are fully aware of it or not. And sadly, I call this the maladaptive coping strategy of the 21st century, where kids are engaging in non-suicidal self-injury, cutting or burning or reopening up scabs or wounds, right? So why do kids do this? And this is important because it's not, I'm going to talk about this under the auspices of non-suicidal self-harm, but this is going to be relevant to how we understand many of our kids' problems. Many of our kids engage in problematic behavior, including cutting, to regulate emotions. And it turns out, using cutting as an example, excuse me, if they cut themselves after a relationship breakup and they are cognitively distracted by it, first of all, and then physiologically, it releases chemicals in their brain where they feel calmer and relaxed. It actually works to suppress negative emotion. Now, I am not wanting to kind of applaud the behavior, but I want to validate the students in the sense that it works reducing emotional distress, okay? And I want to say, I get it. If that's what they tell me, that it works that way, I get it. The question is, can I give you some replacement behaviors so that you don't have to resort to that behavior to get some relief from your emotional pain? And so I often will draw out some version of this illustration on a dry erase board or a piece of paper to talk about this with my kids and the families I work with, and talk about some cue or prompting event, a relationship breakup, something that happened at school with a peer, could be something unrelated to friends or boyfriends or girlfriends, but a subgroup of our students experience intense emotions, and it is so painful and so aversive. And they learn that if they engage in some of these behaviors on the right side of the screen, refusing school, screaming or hitting, binging or purging, self-harm, alcohol or drugs or gaming, or even social avoidance, they get temporary relief from the anxiety, from their shame, from their sadness, from their anger. And from a learning theory principle, they actually, if it's negatively reinforced, they're more likely to keep doing it, right? Negative reinforcement is the principle of you feel some discomfort, you do something to get relief, you're more likely to do it again. So if you have a screaming headache after my presentation and you take two Tylenol, next time you have a headache, you're gonna say, okay, I'm gonna take two Tylenol if I'm gonna get relief. You're gonna do it again. So it works. So what I want you to begin to understand from a DBT perspective is, what if we can teach our students a myriad of distress tolerance skills and how to distract themselves, how to soothe themselves, how to bring down their physiological arousal very quickly with these distress tolerance skills, and give them what I call replacement behaviors. So instead of screaming, instead of running out of the classroom, instead of social avoidance, What can they do to tolerate their distress and not have to escape this way? That's for starters. But the myth about DBT is, oh, we're going to just give them distress tolerance skills and that'll be it, like a Band-Aid. And these are kind of, what I'm talking about now are crisis survival skills to get through the moment so they don't make their situation worse. But really, any good kind of counseling will help kids move further back in the chain and have them learn how to experience negative emotions without escaping. So how can I feel sad and not lay in bed? How can I feel angry and not punch the wall? How can I feel ashamed and not keep hiding? So we're going to work therapeutically and help these kids learn how to experience negative emotions and not escape, right? So this is part of my conceptualization for many maladaptive behaviors that your students are engaging in. And it's helpful to talk to the kids and the parents and the teachers and administrators about this conceptualization, because it tells us where to intervene. It's kind of a non-judgmental way of thinking about this, right? This is learning theory. They're going to do things that get them relief. It makes perfect sense. Without replacement behaviors, they're going to keep doing it. Now, will vaping be here for the rest of our lives? I just want to add this because I know many of your students are juuling and vaping, and it is a very hard problem. We don't know the extent of it yet. It is a study from a couple of years ago of 45,000 8th, 10th, and 12th graders talk about how 11% of 8th graders used a Juul or vape pen in the past year. A third of 12th graders was vaping in the past year. So it is prevalent. That was just a few years ago. I'm sure the numbers, unfortunately, are getting higher. Most people who are using substances are getting worse during the pandemic, so I'm sure those numbers are higher. I also want to make mention of risk behaviors for those of you who work in elementary school, because there are a lot of young people who are in 3rd or 4th or 5th grade who are exhibiting, and even younger, temper tantrums, aggressive behaviors, disordered eating and sexualized behaviors, interpersonal challenges, poor attentional control, highly impulsive. So we are starting to see elementary school students. I'm sure you see some of them, those of you who work in elementary school. These are precursors to more of the severe behaviors I'm talking about. And I know some of your schools may be using Ruler in elementary school, which is wonderful in the sense of it complements DBT well. I'm not an expert in Ruler, but from my understanding of it, it definitely helps with emotional identification. So kids can learn how to identify emotions better. And what DBT does really well is give concrete, specific skills and strategies on what to do when those emotions show up. Like, it's great to notice that emotion, but what am I supposed to do with it now? And DBT is going to teach a range of emotion regulation skills in addition to all those distress tolerance skills that I was talking about as well. I know some of you are interested and curious, as I am, about what happens to these kids who go through our school districts, right? The elementary, middle, and high, and then they launch off to college. Where do those kids go and how are they faring? So my colleague, Randy Auerbach, published a study 2 years ago, looking at 14,000 college students from around the world. And here's the reality, which is kind of painful, that I wanted to brief you on. About 1 out of every 3 college students surveyed suffers from a mental disorder in the past year, right? Of those college kids, right? These kids are going off, 1 out of 3. And sadly, many of them are also struggling with suicide on college campuses, where in this study from a few years ago, there were more than 1,000 college students who died by suicide in 1 year. So that's 2 or 3 deaths by suicide every day. So these kids are struggling after they leave our nests and our schools. And so it begs the question, ladies and gentlemen, what are we doing wrong that so many of our young people are struggling into young adulthood? And is it our responsibility, I ask you, to teach them life skills, right? We are fully responsible for teaching them English and math and history and science and foreign language. I guess what I'm believing now, having been doing this for 25 to 30 years, is that we need to figure out how to teach them social, emotional, coping, life skills that I use in my life now. And I really believe, having been teaching it for 25 years, how much they benefit from it. Because if you look at a lot of colleges like UC Berkeley, right, a top college, hundreds of students are signing up for adulting courses. They're saying, teach me how to function as an adult. I haven't been taught that. And it's not just about balancing a checkbook, you know, making macaroni and cheese and doing your laundry. It's also about, how do I function emotionally? How do I deal with distress and not escape, avoid, use drugs, and so on? They are screaming for help. And more colleges are now adding kind of these life skills, adulting courses. I have a colleague in Seattle, Washington, who's doing it there. So it's happening. So my solution that I'm here to talk about is this dialectical behavior therapy. And as you're hearing from me, it's a skills-based curriculum that helps our students with social emotional problem solving. And it's true, it was originally developed as an intervention in a clinical setting. I literally, with my colleague Jill Rathis and Marsha Linehan, who developed DBT for adults, we adapted it for adolescents in the inner city. And it has since kind of been, I'll show you, been researched and disseminated clinically, but then we've been evolving into more general school-based programs. And it's used in many schools now. We've been in 70, 80 schools teaching coping skills to improve emotional and behavioral regulation. And subsequently, we believe it helps educational functioning and developing critical life skills. And the skills are meant to be applied throughout the school day, at home, and during the school day, students can be coached, literally, like a basketball coach. I'm having an urge to do something, what should I do? And it might be the school counselor, it could be a school psychologist, it could be a gen ed teacher who says, here's what I want you to do, try this skill, because we're gonna train the staff in the same skills that the students are learning so they can coach them and hopefully not have to leave the classroom. We actually help them create crisis survival kits. So in elementary, middle, and high school, they may have something in their desk drawer or their backpack where they can use to temporarily, if they're really distressed, distract or soothe themselves and not have to go into the assistant principal's office and sit there for the day, but rather manage their distress in the classroom, 10 minutes, 15 minutes, hopefully, and not have to abort the mission and stay in math class, re-regulate, refocus, and carry on. So there's a lot about that which we can talk about too. But the 5 main problem areas that we see with these young people kind of fall into these categories. I've already alluded to this emotional dysregulation, which either is fast, intense mood changes, right? Where they, 1 minute they're fine, then all of a sudden they're anxious and panicky or angry or ashamed, but they're what I call emotionally labile. And there's other kids who have steady negative emotional states, steady anxiety, steady depression, where they cannot get themselves out of it. They don't have control over the volume knob of that emotion. So on the right side, we're going to teach what's called emotion regulation skills. How do you identify emotions? How do you reduce your vulnerability to negative emotions? Like, we're going to look at their sleep. We're going to look at their eating. We're going to look at their exercise. We're also going to look at, how do you increase positive emotions? Are you engaging in pleasurable activities? You may know if someone's depressed, they don't feel like doing pleasant activities, but there's a definite correlation. So we need to prescribe some pleasurable activities, a few through the day, so they can actually have better mood, okay? And so there's a whole host of emotion regulation skills. So that's for problem 1. Problem 2 is impulsivity, because if you are emotionally dysregulated, as many of our students can get to, they sometimes act impulsively. They lash out, they text or post something impulsively, they sext, they drink, they do other impulsive things. Sometimes they avoid because they can't manage their distress, so they escape, as I talked about earlier. They need a whole host of distress tolerance skills. There's 2 classifications of distress tolerance skills. There's what we call crisis survival skills. How do you soothe yourself to get through the moment? How do you distract yourself? And you're saying, Alec, why would you have students distract themselves if the goal is to be more aware and present? Well, I only want them to distract themselves when their stress is that high and they need to bring it down so that they can kind of refocus and engage in life again and not make their situation worse, not cut themselves, not drink, not binge or purge eating wise, right? Whatever it may be, there may be extreme behaviors. I want to sometimes temporarily distract. I want them to weigh the pros and cons of engaging in problematic behaviors or not. And there's many other crisis survival skills that we teach with acronyms that help them memorize them. But there's also a set of skills called radical acceptance skills, reality acceptance. I talk about my own psoriatic arthritis experiences when my knees swelled up years ago in my 20s, and I was having trouble walking around. I was in a lot of pain. And I kept saying, why me? This isn't fair, right? I was angry. I was bitter. I was definitely down from that experience. And I was perpetuating my own suffering because I had this psoriatic arthritis in my knees. And the why me, this isn't fair, was exacerbating my suffering. As opposed to saying, I have psoriatic arthritis. I could take some anti-inflammatories. Maybe I can go to physical therapy. I can see it for what it is. It doesn't define me, and move this black cloud away. Now, it sounds so easy the way I put it in this simplistic way. But I tell this personal story to my students because I want them to see I'm a coping model. I'm not a mastery model. I'm using these skills myself. And I want to teach them how they can work on radical acceptance. And we have a whole set of worksheets to help them get to that point. But what do they need to radically accept? Their parents got divorced. Their dog died. They have to radically accept, some of them, that they have a learning disorder or a mental disorder or a chronic physical condition, and so on and so forth. So there are many things that these kids need to radically accept. And that's not one you just do one night and you have it. That takes time to really work on radical acceptance. So you see there's emotion regulation skills, distress tolerance skills, and then we have a whole host of interpersonal effectiveness skills to deal with these kids' social challenges. Many of the students you're dealing with, I'm sure, have trouble maintaining or creating new friendships. Many of your students have trouble effectively asking for what they want or effectively saying no thank you to unwanted advances, unwanted drugs or alcohol. They don't know how to assert themselves in a way to keep the relationship and still say no. That's the classic peer pressure dilemma. Okay, I want to keep a friend, so I'll just do this. We're going to teach them what we call the dear man skills. And then there's what we call the fast skills. How do you keep your self-respect, right? And so on and so forth. There's a whole host of interpersonal effectiveness skills. By the way, there are 33 different skills that are comprised in this whole package. There are many kids who get black and white in their thinking, because if you're emotional, so goes your thinking. Right or wrong, good or bad, non-dialectical, right? So just for example, this is an amazing technology, right? This has my photos, this has my my email, this has my calendar. I lean on this as one of the most amazing inventions I've ever seen. And at the same time, I sometimes get mentally hijacked by this while talking to my kids or my wife. If it vibrates, it affects my relationship. For some people, they're up all night, like I said. And some people are highly addicted to this in a way well beyond my challenges. So it's both a wonderful thing, and at the same time, it's a problem. So dialectical is this idea of both can be true. Multiple truths, not is either good or bad, right or wrong. I'm really serious about teaching DBT. Like, this is so important to me to get this out to people, to help them understand and learn this. And I can be playful and silly at the same time. I'm not either just serious or I'm silly. I'm both. This is important to have our kids, their parents, and even teachers begin to think more dialectically and flexibly about things, and less in black and white terms, because when we do get polarized in our thinking, and we don't have to look too far to look in Washington, D.C. and other places, you can see when people get polarized in their thinking, one way, well, there's only one truth, you can really get off the rails emotionally and behaviorally too. So how our thinking affects emotional and behavioral functioning big time. We also know that there needs to be more work on validation, because many of the kids we work with feel invalidated, not understood. People don't understand my pain, my thinking, why I'm acting certain ways. And when you feel invalidated, you actually get more emotional dysregulated, either launching out, lashing out, or shutting down. I'll talk more about this. So we're going to teach a host of walking and middle path skills. And last, but certainly not least, is this idea of reduced awareness and focus. How many of your students, when asked, why did you do that? Why did you yell at the teacher? Why did you punch the wall on the way out? Why did you run out of the building? I don't know, I just got upset. So it's like this increasing emotion comes up or urge comes up, they don't see it coming. I'll talk about that more in a minute. And many of our kids are having trouble focus. So they're looking at the teacher, but their mental camera lens gets distracted by another student on Zoom or in person. They get mentally hijacked by other thoughts about what happened yesterday, what's happening tomorrow, and they're not in the moment. What if we could teach them how to focus better? What if we could teach them how to be more aware of their urges and emotions and thoughts in real time? This is core mindfulness skills. So I'm gonna refer back to this in a moment. So in '95, my colleague Jill and Marcia and I started this book, and we really became a clinical intervention for higher risk kids. But and we wrote a skills manual on the right, which is used now in schools and clinical settings for all kinds of issues and problems, day-to-day life problems. I also had the privilege of going to Norway and training them in DBT, and we conducted a randomized trial that we published with positive outcomes. If people have questions, I'm happy to answer them here, but I didn't want to get into all the gory details about the clinical research. But over time, DBT in clinical settings has been adapted for all kinds of populations with more severe bipolar and eating disorders and ADHD and conduct problems, but in outpatient settings and inpatient settings and day treatment settings, but it's also being used a lot in schools, which I want to talk about. But what I love about DBT is that it's transdiagnostically applicable, right? If you have problems with regulating emotions, impulsivity, interpersonal challenges and whatever, we are going to give you the tools to manage it, regardless of your diagnosis. And the current state of mental health in schools has been historically very siloed. We're going to teach you the bullying prevention program, that's this. We're going to teach you drug and alcohol prevention, that's this. Sex education, that's this. And what we really feel like is the students really need a common foundation of coping strategies that cut across everything. And so that does tie in with the DBT skills I'm talking about. So after years of working downstream and doing empirical intervention and investigations and research into outpatient DBT, a colleague of mine in 2008, Dawn Catucci and her colleagues at Ardsley High School said, hey, can you take this comprehensive outpatient model, which is multimodal, and bring it into our school setting in Ardsley? And I said, yeah, let's try that. And they really said, we have kids who we are having trouble managing. They're not staying in school. Some of the high risk kids are hurting themselves. They're going to the hospital. It's been really challenging. So we brought that into comprehensive school-based DBT, which I'll tell you about. And then several years later, we said, what if we actually went further upstream and gave these life skills to everybody, universally classroom DBT? And we published a book on that called Steps A. So Universal Classroom is DBT skills in schools, literally lesson plans for teachers, written in 42-minute, 30 lesson plans, 42 minutes. Teachers say, open your book, here's the lesson of the day, script it out so teachers can literally follow along, teach those skills to their students. Obviously having some training in it helps, but the manual is very straightforward, written in lesson plan format with quizzes and so on. And as you'll hear afterwards, there's some schools that are doing this for credit, like life skills classes, in Staples High School in Westport and other places. Some people are using it in general ed classrooms, some of them using advisory sessions with counselors, special ed, all across the board. But that's like a weekly life skills class as the primary intervention. Tier 1. And then tier 2 is this comprehensive school-based DBT, which is this white manual, which I alluded to, which is a little bit more has a little bit more clinical richness to it for kids who are having more obvious trouble with emotional regulation or behavioral regulation. So they have a weekly life skills class, DBT class, plus weekly individual counseling, where they have diary cards and they're tracking their behaviors and their emotions and their skill use. There's also coaching during the day. So if a kid needs some coaching on how to apply the skill, they can go to one of the people who are trained in DBT and hopefully get a 5-minute coaching, like a timeout in a basketball game. Coach, I'm having this problem. What should I do? It's a full court press. How do I break the press? Try the skill. Ready? Go. Send them back out to class or lunchroom or whatever. There's also a weekly DBT provider meeting where those who are delivering this modality, skills class, individual counseling or coaching, sometimes administrators want to come to. If they're involved in any discipline or dealing with kids who are having trouble, that's a weekly meeting. And that's support for the providers. Now, remember I said that burnout issue is pretty high and rampant among schools and clinical settings? We here at CBC have a weekly therapist consultation meeting, which is therapy for the therapists, supporting each other, working on this intervention with kids and families. And we have found that the schools who do this intervention find it so helpful to have an hour a week where they get together and support each other and make sure they're delivering this to fidelity. And so we're going to offer consultation to those teams to best help implement that over time. So we have our consultants going into those teams every other week for a year or two and helping them get there. And then some schools also have parents learn these skills. They might have a parenting workshop for an hour, hour and a half, once a month or something, so that the parents learn the same foreign language of DBT skills. Now, why do this in schools? Well, the rationale is it's cost effective. It provides students and staff with a common language and toolkit, all that social emotional learning course that I talked about. It lends itself so well to being taught in groups and classes and improving social emotional functioning and academic performance. This intervention is uniquely good at reducing numerous problematic behaviors that result in suspensions, ER visits, psychiatric and medical hospitalizations that actually interfere in education. Keep the students in the school building, which is where they need and want to be, and we want them to be. And as I said, this intervention, we believe, can reduce staff and administrator burnout. And lastly, it's evidence-based and has measurable outcomes. So I'm going to show you a few data points from some of the schools we've dealt with. Ardsley High School, I mentioned before. They kind of did this open trial. They presented this at a conference about 10 years ago, where they had reduced referral, when they did comprehensive DBT, kids who were really kind of affectionately known as frequent flyers, who were showing up in administrator's office and school counselor's office, there were reduced referrals to the assistant principal, less cutting of class, fewer detentions, fewer suspensions. And while we didn't have all the evidence-based measures, anecdotally, there was reductions in depression, anxiety, and self-harm. And they did say, though, there needs to be a little bit of a change of culture in how the schools manage problem behavior. And I'm going to come back to that. My colleague, Alicia Dad, who's on this call, who was at Pleasantville, did her dissertation many years ago, went up to Staples High School in Connecticut for several years, and then had the privilege of her joining our practice several years ago, and now runs school consulting for our entire agency. And she's on the call and she can answer some questions. But her dissertation found, using the BASC, that there were reductions in depression and social stress and improvement in adaptive coping and specifically mindfulness skills, and also improvement in tolerating distressing situations. Also suggesting, though, there may be some changes of culture, and we can talk about that. So years later, the Hallorans unfortunately lost their son, and they created a foundation called Break the Hold, and their commitment was, hey, let's take this DBT curriculum at Pleasantville High School, and they're now going to other schools too, and trying to give these life skills to everybody they know. And the mother, Jolena, said their son didn't know how to verbalize it, so this is why we think it's important. The education as a school to give kids verbiage to recognize what they're feeling. So they have been using the Steps A curriculum there. But I just want to tell you about one more school called Lincoln High School, which is in Portland, Oregon. I was not involved in this training or research at all. But my colleague, Jim Hansen, who was a social worker there, he worked with 1,700 students, middle to high socioeconomic status. It's ranked one of the 100 best high schools in the country. And as we all know, sometimes with that ranking is higher pressure, higher stress. And so suicide had been the leading cause of death in that school for a while. So he took the highest risk kids and provided comprehensive DBT to 56 of them in high school. And just take this in for a minute, because I was so staggered by this, and he's hopefully going to publish this in a journal very soon. Before DBT, there were 1 or 2 suicides every year. And since starting his DBT program in the school 9 years ago, there had been none, no suicides. 1 or 2 a year to 0 in 9 years. Before DBT, there were 2 placements into the Portland Public School Day Treatment Classroom for a year for emotion and behavioral dysregulation. And since starting DBT, there was 1 placement in 9 years. So think about those outplacements and the cost of that alone, and the effect of that on the child and the family when they have to be outplaced. And by the way, in case you're keeping score at home, he found statistically significant improvements in the GPA from pre to post intervention. And on the BASC, those that many of you know is an assessment of emotion and behavioral functioning among children, real impressive reductions in anxiety, depression, internalizing, and improvements in anger control. So even in the emotional domain too. So really nice outcomes. So as I mentioned, we started in Ardsley in 2007, 2008, and they told a couple of friends, and then they told a couple of friends, and we've been really disseminating DBT around the tri-state area, including Fairfield County. And then we've been working in some other parts of the country as well, North Carolina and Colorado. So it's really been the last bunch of years an incredible experience to start disseminating this intervention around the country. And I give you a list of schools here specifically in case you have friends or colleagues and you want to talk to them about their experiences of what we've done in these schools, public and private schools around the area. There was a news story, by the way, that I'm very proud of that came out about a year ago at Hendrick Hudson High School, and talked about how effective comprehensive DBT was in their school that we've been training for years, and they've been doing an amazing job. And I have to check, I can't remember in Connecticut now whether the governors has passed a law, but there is now in New York and New Jersey mental health education required as part of their school curriculum as of the last couple of years. And in New York State, they developed mental health education literacy and school guidelines. DBT is one of the recommended tier 3 support for students with high need. And I'm hoping to get it into tier 1, tier 2 as well. I assume it will be shortly. But what I love about the Dalai Lama quote is that when educating the minds of our youth, we must not forget to educate their hearts. So what do I want to show you now? I'm mindful of the time, and I want to leave some time for discussion. Speaking of mindfulness, I think I covered enough on mindfulness. Well, let me just make one point about mindfulness. We have a whole workbook on it, and I'll play a little clip of something that I have here.
So when we talk about the 3 states of mind, you have emotional mind, then you have reasonable mind, and you have this Venn diagram where they overlap called wise mind. So let me explain these 3 states. Emotional mind, when it's a problem, is when you're fully immersed in this negative emotional or intense emotional state. There could be positive emotions of excitement, and I'm so excited to play video games. I'm going to play Fortnite all night. This is great. And you can see how that could become problematic if you're not sleeping at all and you forget about doing your schoolwork or not even eating meals. That's a problem. If you're also in emotion mind and feeling intense anxiety about something at school, and you just avoid and you just stay home and refuse school, that's a problem. If you feel so sad sometimes and you pull the covers over your head because you're starting to get more depressed and you can't think about anything else, that's a problem. There's also advantages to emotion mind while I'm on it. There's sometimes when you're just immersed in some intense sadness or grief after someone passes away and you have a good cry, that makes sense. Or if you're crossing the street and all of a sudden you hear a horn blare, you get anxious, you get afraid, and you jump right back onto the curb. That could save your life. So that emotional intensity in those moments can be advantageous. So you can see in that state of mind, there's some advantages and disadvantages. On the other side of the dialectical seesaw is something called reasonable mind. And just the term alone should help give you some explanation for what that means. Reasonable mind is logical, rational. It's like calculator mind. I need to go shopping. Do I need milk? Do I need bread? Yeah, I need some cheese. Okay. I'm not getting too dysregulated about that. I'm making my list of things I have to shop for. Or I'm going on my computer and I'm looking down my drop-down menu of cut, copy, and paste. And I'm going to use that in my Word program. Okay. Again, not too emotionally arousing, but I'm using this logic and reason to kind of carry on some of my activities of daily life, which is helpful. But you can start to see, though, if I'm making all decisions in this reasonable mind state, just the facts without emotion present, that might be problematic if I'm deciding about, do I want to stay in this relationship with this person? Is this the right person to date? Should I kind of carry on with doing my work tonight or not? Is there enough anxiety for me to kind of say, if I don't get my work done, there may be consequences. So having some emotion present when I'm trying to make some decisions is useful. So pure reasonable mind, I would say, when you have to start making important decisions, is not ideal either. And so what I'm getting at here is the advantage of these three states of mind is we want to teach these teenagers and parents this notion of wise mind. How can you synthesize some emotional experience and information from your emotions coupled with the facts of the situation that's logical and reasonable to make an informed decision? And there's so many things that I myself even every day have to find my wise mind. I've been working hard lately. Do I want to still get up early and exercise? Or am I going to just sleep through my exercise session? Am I going to eat this extra chocolate cookie? Or am I going to have just one and let those other ones go to other people? Am I going to hit the snooze bar one more time and sleep through my meeting? Or am I going to get up at a designated time so I can be productive today? So those are daily life things. But many of our patients get emotional and they have urges to hurt themselves. Self-injury. They may have urges to use drugs or alcohol. They may have urges to lie to their parents. And the question is, can they access their wise mind before making these impulsive, possibly self-harming decisions or harming their relationship so that they don't make their problems worse and maybe have a better chance of a more positive outcome? That's where we want to teach them how to access.
So that's just an example of something we created recently for professionals. So like a training video, but I thought I'd give you a succinct example of this 3 states of mind worksheet that this is what we give to the kids. And we may show other videos, not the training video that I shared with you as professionals. But I do want our kids to learn how to access their wise mind. And there's a whole set of skills on how do you observe and describe and participate. How do you stay focused? How do you practice being non-judgmental? So there's a lot of steps to get into that wise mind, which is the core of the treatment. Without knowing what you're feeling, what your urges are, what your emotions are, all the other skills that we teach become a moot point. So I just want to spend a couple of minutes on this theory of emotional dysregulation, because if we as administrators and school personnel and professionals, clinical professionals, think about how these kids got to be this way, we're going to have a lot more effective compassion for them. And we know how to intervene with them in a more effective way. And what I'm about to share with you in the next 5 minutes is what I tell the kids, some version of what I'm going to tell you, and I tell their families, and I love talking to schools about this. This is the theory of emotional dysregulation. How do kids get dysregulated? There's a transaction between how they're wired biologically, right? And we're going to talk about that, and the environment, which we sometimes refer to as, it can be at times, invalidating environment. And over time, this transaction between how they're wired and how the environment responds to them can yield what we call pervasive emotional dysregulation. But let me break it down for you into these 2 pieces. The biological piece has a lot to do with emotional vulnerability. So I asked the kids, Do you find that you're more emotionally sensitive than other people you know? Do things get under your skin more easily than your friends, brothers and sisters? Yes, some of them will say, I'm really sensitive. I get easily bothered. Number two, are you more emotionally reactive? So not only do you feel things quickly, you feel them very intensely. Not just a little pissed off, but really angry. Not just a little sad or blue, but more profoundly down and depressed, right? Not just a little bit of butterflies, but full-blown panic attacks sometimes. So high emotional reactivity. And when that happens, so goes your thinking process. And everyone in this call knows when you get really emotional, it's very hard to think clearly, level-headed, rationally, and your thinking goes out the window too. And by the way, this is relevant for educators because when some student is really aroused, they can't process new information. So they may be sitting there staring at you either with an evil eye, angry, or just kind of dissociated or out of connection. Either way, they're not processing new information. So we have to figure out how to get them to their wise mind, re-regulated to process again. But there may be a biological basis for this is what I'm saying. And the third characteristic is a slow return to baseline. So when kids get upset, these kids, the subgroup of kids I'm talking about, it may take them a long time to calm back down to baseline. Now, many of us on the call are sensitive. Some of us might be reactive, and some of us may even have a slow return to baseline. However, I'm going to guess that many of us on the call have learned to regulate and modulate emotions better. So on the right side of the screen, you see inability to regulate and modulate emotions. The kids who are coming to DBT haven't learned that yet. So I want you to begin to think about this as a skills deficit, which means we have to train them in learning how to do this. We can't just say, stop it, stop feeling that, stop acting that way. That doesn't work. They need to learn how to regulate emotions. And it's our job, and I say our job collectively, figure out ways to teach them how to regulate emotions better. That's part one of the theory. Then there's the invalidating environment. But what does validation really mean? This is important, guys, because we need to do more of this. Communicating to another person that his or her feelings, thoughts, and actions make sense and are understandable in a particular situation. Now, a lot of parents are like, I don't like this because my son Johnny was playing video games all night, and I don't want to validate that he failed the test when he was crying. But you can, so validation doesn't mean agreement. It just means you acknowledge that he's really sad about failing his test, not that you condone his video game playing. You just know he's really sad about failing his test. That doesn't mean we leave it there. We come back and figure out how to get his sleep back on track and understand there may be some natural consequences for his failing his test and so on. We'll deal with that. But lead with validation. Because the invalidating environment, who is that, by the way? Family, could be family members, could be school staff, definitely friends, peers, calling kids names. I hate you, you're disgusting, you're ugly, nobody likes you, nobody wants to be with you, why don't you kill yourself? If you hear that over and over again, pervasively, that is extreme, right? Mental health professionals, medical doctors, we all could be at any given moment invalidating, hopefully less so than some. But we need to work on this too, because invalidating environments pervasively negate, punish, correct, ignore, dismiss behavior independent of the actual validity of the behavior. So I ask you, imagine the situation where the teen is upset about failing the test I just talked about, and the parent says to you, oh, it's your fault. If you studied more, you would have passed. You know, just that's a little gratuitous piling on. That's, many of us have done versions of that. But I bet many of us have done this. Oh, stop worrying, honey. It's not a big deal. It's only one test. Why are you so worked up about it, right? And you can get into statistically, well, you have 10 tests this marking period or quizzes, and that's only 1/10 of it, so don't panic. And we get into problem solving and reassuring. But that's not validating. What would be validating here? Johnny, I understand you're really disappointed with yourself and upset about failing your chemistry test, period. We can come back to more, but it's acknowledging his experience. We might come into, it's only one part of your grade and blah, blah, blah. We might get into that, but reassurance is invalidating. Oh, stop worrying, honey. It's not a big deal. That's invalidating. He's crying. And you're saying, stop worrying, honey? That's invalidating. So let's be clear about that. The other type of invalidation, and by the way, I've done all these to my kids at one moment or another, my family, my friends. I'm working on it. I'm getting better. But I'm saying we all of us sometimes do this. I've gotten much better at it. Not invalidating, doing more validation. But the second type of invalidation is where you ignore or punish lower levels of emotional display and then intermittently reinforce escalation. So the parent says to the kid who fails a test, "You're overreacting, Johnny. It's not that big a deal." Johnny starts crying more, escalating. "You know what? I'm not even going to go back to school now. So take that, Mom. I'm not even going back." Then Mom says, "Oh my, well, Johnny, you know what? Let's go out for a nice dinner. You'll feel so much better. I'll help you study more next time. I'll give you some Hershey Kisses. What do you want? Do you want pizza? You want steak? This is your night." Wait, what? What just happened there? Mom missed the opportunity to validate at a low level. Johnny escalates, and then Mom reinforces the escalation by rolling out the red carpet, by giving all these goodies. Now, this mother's not the only one who's done this. This happens in schools too, where the squeaky wheel sometimes gets the grease. I had a private patient referred to me from a local high school in Westchester, was seeing a school social worker every day. Worked with her for 6 or 8 weeks, started doing a little better in my outpatient program, and wasn't as distressed at school. And so one day there's a knock at the school social worker's door with my patient in the school social worker's office, and the assistant principal said, "This kid that you're seeing, my patient, seems to be too under control, too emotionally regulated, but I got a kid out here who really needs your help, social worker. So can you knock that kid out, my patient, and bring this kid in?" My patient said to me, "Alec, I swear, I feel like I have to escalate to have more time with the person who I like at school." I said, "Okay, before we go that way, let's think about how to get there without escalating again." So think about how inadvertently in milieu settings, schools, hospitals, and other places, we sometimes attend to and reinforce emotional escalation, and we don't attend to lower levels of emotional display. And I'm not judging anybody. We're all doing the best we can. We're all working our tails off, but I want us to be mindful of the culture. And when I talked about that research earlier that Alicia did and Dawn and others at Ardsley, changing the culture includes not running around like an emergency mass unit and thinking about how to reinforce and validate lower levels of emotional distress and not just attend to the crises only. And the last characteristic, by the way, I've done this too, but my favorite example, where you oversimplify the ease of problem solving and meeting goals. Well, you tell the kid, "Just study more next time, you'll do great." "Nah, fine, you'll be fine. No worries." My favorite example is Nancy Reagan back in the 1980s. Some of you may recall, every first lady has their platform, and her platform had to do with substance users in the world. And she said, "Ladies and gentlemen, I'd like to announce, please have a seat because this is going to be blowing your socks off. For all the substance users in the world, I want to tell you this. Just say no. Thank you so much. Thank you. Thank you. Just say no. A methadone maintenance, drug addicted human being for 20 years. Just say, oh, thank you, Miss First Lady. I never thought of that. That's a great idea. I should have just said no. Think about how oversimplification is so invalidating. And when you get invalidated, like I said before, you're either going to get angry and attack. What are you talking about? You're ridiculous. You don't understand. Or shut down, withdraw, and not talk to that person because they don't get it. And so you might know if you have a student in your room who's really getting riled up or really shutting down, that may be an indication that you may have inadvertently invalidated them, and we can work on validating their emotional state to help them regulate. And then work on whatever we got to do to problem solve whatever the situation is. I'd like you to all think about how we can train ourselves and our colleagues to validate first, grease the wheels, have a better connection, on mutual understanding, and then we can work on what the problem at hand is. And we teach this biosocial theory to anyone who listens. And so again, there's some other slides in there about some things you can do to practice validating your kids and some examples, but I think I covered it. So I want to make some closing remarks and leave time for some Q&A here. After 25 years, I do believe that the future is looking brighter for our kids, our schools, our clinical settings. I'm really hopeful because there's been a development and dissemination of real evidence-based interventions, not only in clinical settings, which we would expect, but in school settings for kids who are anxious, depressed, self-harming, substance using, by the way. And there are really effective interventions and therapies that are being used around the world for these populations, and elementary, high school, college counseling centers. And what I'm really proud of is this effort for, simultaneously target 2 and 3 kids, but also tier 1 through 3 kids. And we're really working on prevention and a universal work on tier 1. And taking into account staff stress and staff burnout. We have to honor it. We can't pretend it doesn't exist. We have to look around and say, we're all human beings who need support. And we can't just pretend that this doesn't exist. This is tough stuff. I love that the New York and New Jersey state law require mental health education. I love that there's been stigma reduction in my career that I've witnessed. And we talk about these different in schools in Fairfield and Westport who have Zen dens where they're going to get a place where these kids can go and unplug and soothe themselves for a little while and be able to then go back to class. Faculty members are using these Zen dens too. Some of them may be on the call today to speak to it. Their mental health, student councils in schools. And then the celebrities are joining the cause. Some of you may know Bruce Springsteen's autobiography, if you haven't read it yet, about Born to Run, talks about his own depression, his own pharmacotherapy and psychotherapy that he's had has helped him. Selena Gomez talks about how DBT has changed her life, and she wishes more people would talk about it in Elle magazine. Lady Gaga, in an interview with Oprah, talked about how she struggled for the first time with self-harm, and she used some of the DBT skills called the TIP skills, which I didn't go into today, that help her get through the moment when she's having urges. My friend Brandon Marshall, who is just retired as an NFL All-Pro wide receiver, played on 6 teams in the last 12 or 13 years. And he grew up masking his pain, hiding it, not talking about it. He thought that was tough, and he didn't realize that he was not effectively managing his emotions until Roger Goodell of the NFL said, Brandon, your behavior on the field and off the field is highly problematic. And unless you get professional help, you cannot stay in the NFL. So he agreed to go to McLean Hospital, got diagnosed with borderline personality disorder, and basically became a tremendous advocate and spokesperson for mental health awareness and destigmatizing mental illness. And he and his wife, Mishi, wonderful people, started an organization, Project 375, that I was a proud board member for several years. And they go into schools and they talk to students. And he would say to, auditorium full of kids, I have this disorder. Is anybody else? And kids like, I have anxiety, I have depression. And it wasn't just self-identification. It was talking about there's nothing to be ashamed of. You don't have to hide from it. There's help. There's treatments that are working. Tremendous. Glenn Close, some of you may know, her sister and nephew struggled with mental health problems, and she started an organization called Bring Change to Mind, also very outspoken about bringing more light to the subject of mental health. And I had the privilege with Glenn Close and Brandon Marshall and some others, the state senator Stabenow in Michigan, to go to my alma mater at University of Michigan and hold this incredible discussion, who can relate, with students and faculty. Again, trying to bring awareness to the University of Michigan. And it was a wonderful weekend with athletes and actors and students of all kinds of faculty. And Peter Tunney was there. He used to be a Wall Street guy, had some mental health and substance use problems, got help. And now he has so much gratitude for mental health awareness. He's an advocate. He does message art like this, mindfulness, gratitude, and goes around the world talking to students and adults about this as well. So I have a lot more I want to say. I want to make sure we have time for discussion. So I want to just thank you for giving me this time to begin to start this discussion. And I want to invite my colleague, Dr. Alicia Dadd, and Bill and others to have some conversation. And I can stop sharing, Bill, if that makes sense to, there's more information, by the way, in your slides, if you printed them out, about our organization, if you want any. And I know, I think Karen may also want to have some slides too to show.
Thank you, Dr. Miller. I want to introduce Dr. Miller's colleague, Dr. Alicia Dadd, who's the Director of Consultation Services at Cognitive and Behavioral Consultants. Dr. Dadd is a full-time psychologist and a certified school psychologist in both New York and Connecticut, with 13 years of experience providing counseling services, conducting evaluations, and developing social emotional programs for a wide range of students. So welcome, Dr. Dadd, and thank you for joining us to address questions from the audience. And boy, we've had a lot of questions, probably won't get to all of them. So just kind of a point of clarification first. One listener asked about the difference between DBT and CBT. If you could just address that quickly.
Yeah, real quick. CBT is kind of the foundation of DBT. In other words, DBT is CBT plus other things. We took the best of cognitive behavioral therapy, which are the change strategies, changing thoughts, changing behaviors, and added a whole body of work on acceptance strategies, of validation, of radical acceptance, and synthesized them together. And in DBT, we're moving between change and acceptance moment to moment with our students, with our colleagues. So it's kind of CBT plus with a very nice package of those skills I talked about that covers so much breadth and depth for students. So it's a pretty broad skills package. I don't know if you want to add anything more to that, Alicia, or did I cover that?
That's a great summary of kind of, and with DBT, like Alec had said, we have kind of these packaged skills kind of ready to go and user friendly. And you know, as you mentioned, there's the manuals that are very user friendly and adaptable for different age ranges as well.
So that brings up a couple different points that some of our listeners have asked. One is adapting DBT either for the virtual environment that some schools are finding themselves in, or even if it's in person, if you're requiring social distancing and masks in your school. Are there adjustments that can be made for the realities of our COVID situation and what it's done for education?
I'll let Alicia's was at involved with several schools this week, so I'll let her talk to them about that.
Yes, hot off the presses. I think this is a lot of our current consultation. I actually think that DBT does lend itself to doing things virtually. For those people who are trained, it's easy enough to kind of provide PDFs and share screens online to do instruction. We've actually led our groups. I think the Monday after everything closed down, we went all remote. So we work with our teams to do mindfulness activities that can be done remotely. We've structured a lot of our resources so that they can be adapted to the virtual world, and we've continued to operate in that way. So I think that that it's very much able to be adapted to the current situation.
Great. And there's also a question about using this at an elementary level, and are there specific resources for working with younger children?
Go ahead, Alicia, you want to take it?
Sure. So currently the manual as published is for, we generally think of it as older elementary, maybe third and up, because there is a certain readability and things like that. We do have a version of an elementary manual that's unpublished that we actually right now are working with some of our teams that have been using it in an adapted version to kind of continue to tweak and hone the lessons so that they're even more elementary friendly. So there is an unpublished version, and we're continuing to evolve and kind of build on that as well.
So for K through 5, that we give them, when we consult with them, the unpublished version, and it has been developmentally downwardly adapted with really good examples for that age group. The other manuals are really for 6th, 7th grade and up. Yeah.
And there was a question about how much the students need to kind of understand the theory behind all of this in order to make the curriculum work in terms of the lessons. I mean, is there a lot of background work that you need to do with them, and so that they really understand how this works with the brain and that type of thing, or can you just kind of launch into the curriculum?
Yeah, you really don't have to go into the theory. I'm emphasizing it obviously for our professional audience and for some older adolescents who want to better understand how they got to be this way. We have very more simplistic ways of explaining how they're wired and how the environment and so on. So that's the biosocial is the one theory that we might do a little explaining of, and sometimes for older kids I might explain how things get reinforced and whatnot. But most of the theory is not explicit. And we get right down and dirty into teaching them skills.
Mhm. And with the curriculum books that you showed, how has that been integrated into schools? Is it a separate course or integrated into an advisory, or what's the different model? And is there a recommended frequency for using the lessons?
Alicia, you want to take it?
Sure. So I think with the comprehensive, there's usually that group component, and then there's also the individual counseling. So sometimes that's integrated into maybe counselors already running pre-existing groups. Maybe they create a small pull-out group of individuals who have, 3 or more problems within those areas that Alec kind of described earlier. There's also many iterations of how it's being implemented. So when we consult with schools, we look at where's there an opportunity and how can we kind of make it work within their system. So as you mentioned, some schools are doing it integrated into their health curriculum. So they're breaking down lessons so that the health teachers are actually delivering the lessons as part of an 8th grade health curriculum, and then maybe again in 10th grade. Some schools are doing it in some of their core classes, like everybody takes 9th grade English and 9th grade history. So they're teaching it in the context in a push-in model. Others are actually, doing it where they have, like I said, that advisory or small teams. They're doing it in team meetings. And then, as mentioned, some schools are doing it as an elective course. When I had left Staples, we were teaching it as a wellness seminar, which was a half-year credit-bearing pass-fail class, which I have to say, the kids responded so positively and had such a, it was so affirming for them to hear these are skills that I can use every day and think about. Actually, we had some kids took it sophomore year and then getting ready to go to college, they're like, can I take it again as a refresher? So I think we really work hard to understand the culture of the school and where it might make the most sense to fit in.
Great. And what, I'm just looking at some of these questions that are coming in. One asked a couple questions about integrating DBT, and they use specifically Ruler as an example, but with other social and emotional learning strategies or programs that are out there.
Yeah, I mean, my experience in the Bronx, I was at PS8 elementary school where we had PBAS going on. We had other evidence-based treatments, and we also had DBT, and they synthesized themselves quite well. We have worked with a lot of schools who had other initiatives and programs going on, and I think there's definitely smooth ways of kind of having them blend together, including, like I said, with Ruler earlier. We've been to some districts that have been using that. And especially they like that in the elementary level, and we've been kind of layering it on top for elementary, middle, and high with DBT. So I don't know, Alicia, if you want to add to that.
Yeah, I actually, prior to leaving the school setting, I was trained in Ruler as well. And it actually was a very kind of seamless fit, because I think about where something like Ruler increases around that emotion regulation. Sometimes I feel like DBT goes into greater depth and breadth around like the actual skills acquisitions about what to do in those moments. So I think that overall, many of the social emotional programs have a consistent type of language. We tend to be more skills focused as well. So I think that, many of our schools have done the integration pretty seamlessly.
Great. As not unexpectedly, the question has come up about cost and where schools can look for resources for these types of programs and the materials, and obviously there might have to be costs involved in how a school implements it, but just can you talk a little bit about how different schools have looked at that and addressed that cost issue?
Sure. I think typically what happens is I end up having a conversation and in consultation with Alec if anyone's interested, and I believe at the end, if it's not in there, I'll include my email. They can reach out. We get a sense of what the school's needs are, and then we talk about it, and then we really come up with a proposal that includes, one of the things we really do want to ensure is that we know that there's a lot of different social emotional programming, and one thing I think that we're really proud of is that there is a lot of research and evidence behind DBT. So we want to ensure that the program is implemented to fidelity. So with that being said, we have a training model that includes 4 days of training for anyone who may be implementing. It includes Alec going and doing a kickoff and orientation, because as he mentioned, it is all about also the school community understanding the idea of validation and behavioral principles. So we want to make sure, even if everyone in the school isn't directly delivering DBT, they have a sense of this being part of their culture and community. And then we also provide ongoing consultation. So once you're trained, we really want to ensure that you're delivering it to fidelity and also problem solving around some of the implementation. So regarding the cost, it really will depend on kind of what our recommendation is for your training. Sometimes what we will do with schools is we will have Alec come and do a kickoff and orientation as the first phase to assess kind of the overall viability of it. And then we would have a follow-up call to determine training.
Great. And this is just, someone had asked, Dr. Miller had mentioned something along the line that DBT addresses 33 different skills. And is there a list of the different skills somewhere that people should have access to?
I guess the manuals themselves have them all explicitly laid out, but we can, Bill, if you like, we can give you a list to give to you to circulate if that works. We're happy to provide just a list of the 33 adolescent DBT skills for you. Yeah, and then maybe, I don't know, Karen or we can help get it out to everybody.
Sure, no, absolutely. Well, this is terrific. I'm sure there probably are some folks with other questions, but you have just done a tremendous job of making this presentation, and we just appreciate it so very much. And I want to thank you, Dr. Miller and Dr. Dad, for being here to share your expertise with us. I want to thank CAS's corporate partners, IGA and Jostens, for their support of this type of expert professional development for Connecticut's school leaders and all educators in our state. And I want to thank everyone in the audience for attending today. I know this valuable information will be useful to you as you do the most important work there is, supporting, nurturing, and educating all of Connecticut's school children.